Greetings, Patho students, and welcome to week 7. In week 7, we're covering the circulatory function, and in your ebook, that is chapter 17, 18, 19, and 20. In week 7, we also have a case study that's due on disorders of blood flow and blood pressure, and you'll find that in Canvas. That is your second case study, so it's called case study number 2. Let's go over chapter 17 and what I want you to pull out of chapter 17. On Canvas, you'll find a link to Khan Academy video, which is about basically the way blood travels through the heart. And there's something similar to that in your book as well. I like to use Khan Academy videos when they're appropriate. And if you're not familiar with that as a resource, rather than Google something that you'd like some audiovisual kind of explanation to, I would suggest that you actually try khanacademy.com. Just create an account, and you'll find that there's lots of helpful information for all topics, whether you're studying astrophysics or whether you're trying to teach your kindergartner edition. There's lots of helpful videos. They're all short. They're all done by some sort of expert in the field, and most of them have a good graphic quality that, although it may be someone just drawing on a blackboard, on an electronic blackboard, it's a good graphic depiction of whatever the concept is they're trying to explain. So I throw those in whenever I think it's appropriate, and also I want you to know that is a resource for you as well. So chapter 17 is about the control of the cardiovascular system. So the first thing I want you to take away is, what is the relationship between blood volume and blood pressure? That has to do with the phenomenon of hemodynamics. And I want you to know the definition of hemodynamics, as well as list some factors that affect or contribute to the hemodynamics in our body. The next is, go down through your chapter a bit, and there's a section called the heart as a pump. Remember that this is a chapter reviewing the normal anatomy and physiology of the cardiovascular system. So we're not quite talking about disorders yet. But in the chapter called The Heart as a Pump, you'll find a video on myocardial blood flow. So this reminds us where the first video was about how blood travels through the heart, picks up its oxygen in the lungs, and is pumped to the body. This talks about how the heart itself is perfused. How does the heart itself get blood and oxygen? And if you follow the trail, you'll see it's very interesting that as the blood starts to flow through the aorta, the very first place that the blood stops, or the very first tributary that comes back to the heart. Body's very smart, and it's going to take care of its heart first before it pumps blood out, say, to the periphery. So take a look at that video under the section called The Heart as a Pump. And then be reminded, if you have forgotten, or maybe you've never studied the heart before, of the functional layers of the heart: the pericardium, the myocardium, and the endocardium. So the pericardium is a layer, the outermost layer. The myocardium, the myo, should give you an idea that that's the muscle. That's where the actual cardiac muscle lies. And then the endocardium is the inner lining of the heart. Also, the heart valves can be reviewed in this section as well. And I want you to be able to identify your 4 valves. And if you look at figure 17-8, that will be a good review of, actually that is a graphic that shows labeling of all parts of the heart, but it does include the labeling of the heart valves, the 2 on the right side, the tricuspid valve and the pulmonic valve, and then the 2 on the left side, the mitral valve, sometimes called the bicuspid valve, and the aortic valve. And there's also another video called the cardiac cycle video, and this helps you to understand how those valves work with and against pressure, and how they promote the movement of blood throughout the heart and then out to the body. And I do want you to take a look at the conduction system, the electrical conduction system in the heart. Look at figure 1711. I am not going to teach EKG and EKG interpretation at this time. This chapter does go into it, and it actually has you identifying P waves and T waves, etc. I don't think that's really necessary for this course. You are going to be required to take an EKG course as you proceed through nursing, and you will hit the cardiovascular system in critical care very heavily in Block 4. You know, if you're really interested in EKGs, I would suggest you go take a course. If you use it in your work, for instance, you might be an EKG technician, you might have already studied some of these concepts. But I do want you to know about what is the normal conduction of the heart. What is the name, for instance, of the SA node, the sinoatrial node, and how that electrical impulse makes its way throughout the heart. I do want you to identify some terms, not that you're going to be able to recognize them necessarily on EKGs, but identify the term heart block, ectopic pacemaker. So if you think of an ectopic pregnancy as a pregnancy that occurs outside of the uterus, an ectopic pacemaker is a bundle of pacemaker tissue that is not lying in the normal conduction pathway. Causes problems, an ectopic pacemaker. And a premature ventricular contraction, or what we call a PVC, and then the term fibrillation. And we have both atrial fibrillation and we have ventricular fibrillation. So I want you to know what the term fibrillation means. Then moving through the chapter, be able to define diastole and systole, and a couple of other terms. End diastolic volume, and then the term ejection fraction, because we use that, we can measure an ejection fraction through a cardiac ultrasound. We can also measure ejection fraction through a left heart cath when a patient goes into the cath lab. And ejection fraction is an important component of cardiac function, and it helps us to identify the proficiency of that heart as a pump. Please familiarize or refamiliarize yourself with the terms preload and afterload, and this has to do both with cardiac function as well as blood pressure. And the Frank-Starling mechanism, or the Frank-Starling law, that affects the contractility ability of the heart. So just know what that is. It'll be a sentence or two, and then you'll understand what that is. And also I'd like you to look at the structure and function of the arteries, the arterioles, the veins, and the capillaries. Basically knowing the difference between an artery and a vein, what kind of blood do they carry, and also the structure. There is a difference in their structure. For instance, the arteries have a muscle wall, and where the veins do not. I'd like you to look at the structure and function of the lymphatic system only to know what it is. You don't need to get into autoregulation and some of these other terms that they have. So I want you to have an understanding of what the lymphatic system is and how it works with the cardiovascular system. And that is it for chapter 17. So moving on to chapters 18 and 19, these are your two biggest chapters for week 7, chapters 18 and 19. Chapter 18 is disorders of blood flow and blood pressure. Chapter 19 is disorders of cardiac function. So here we start to get into all the risk factors for coronary artery disease, for instance, and all the contributing issues that we see for these kinds of patients. So in chapter 18, I'd like you to again, look at one of my favorite things. There's a section in the beginning that talks about the functions of the endothelial cells. Remember the endothelial cells, the innermost lining? The endothelial cells and their role in the dysfunction of various disorders. And look at table 18-1 to refresh yourself about that. Know the definition of hyperlipidemia. Hyperlipidemia, which is a major risk factor for coronary artery disease. Be able to differentiate between LDL and HDL. My memory tool is really it's like a kindergarten tool. LDL, I think of low down, like low down dirty. Low down, LDL is your bad cholesterol, and HDL is, LDL stands for low density lipoproteins, and HDL stands for high density. And in this case, high density is actually better for us. So HDL is our good cholesterol. So we want our good cholesterol numbers to be high. We want our bad cholesterol numbers to be low, LDL. And you can look at table 18.2 for some help to differentiate those different kinds of cholesterols. Know what the pathogenesis of atherosclerosis, not arteriosclerosis, but atherosclerosis, A-T-H-E-R-O, which means plaque or fat or lipids, atherosclerosis. Read about how the vessel intima, the intimal lining of the vessel, is affected by the presence of these lipoproteins, and then be able to have a discussion, for instance, about ischemia, hemorrhage, clot formation, infarction. When we talk about coronary artery disease, we talk about coronary or cardiac ischemia. And when ischemia is not corrected, then it goes on to infarction or necrosis of tissue. And what are the preventative factors associated with these problems? Also, the pathophysiology of vasculitis. I want you to read about peripheral vascular disorders or PVD. You should be able to distinguish the difference between an aortic aneurysm and aortic dissection. Both of these are very problematic and troublesome to the patient who has that diagnosis. The dissection is much more time sensitive. It needs to be addressed very quickly. So define aneurysm and then dissection. When it comes to differentiating the blood pressure terminology and mechanisms, again, you should know, we talked about systole and diastole. You should understand the relation to systolic pressure and diastolic pressure. You should also know about mean arterial pressure, which we call MAP, M-A-P. If you're in a clinical setting at all and you've ever looked at a blood pressure machine, it gives you 3 readings actually. It gives you the systolic blood pressure on top, the diastolic blood pressure, and then the third number, a lot of people think that's the heart rate or that's the pulse oximeter. The third number usually is, it'll say MAP, mean arterial pressure. And there is a formula. My memory tool for this formula, well, first of all, if you're looking at a machine, it's calculated the MAP pressure for you. And mean arterial pressure is a number that we look at when we're talking about what is the minimum that we need to perfuse all of our vital organs. In general, we would say a mean arterial pressure. Some texts say 60, some texts say 70. I kind of go with 70. I would like all my mean arterial pressures to be reading 70 and above, meaning all my vital organs, my brain, my heart, my lungs, my kidney are all being perfused adequately with a mean arterial pressure of 70 or above. So my memory tool, if you're ever given a test question, for instance, that only gives you the blood pressure, my memory tool is, I think of my dentist as DDS, as a doctor of dental science. So you take the diastolic, D, plus the diastolic again, D, plus the systolic, and you divide the sum of that by 3. So it's D plus S divided by 3 equals your MAP pressure. So take your own blood pressure, and if you don't know it, just say you're a healthy young person and your blood pressure is 120/70. You would take the diastolic, which is 70, so you'd say 70 plus 70 plus the systolic, which is 120, and divide that by 3, and your number should be over 70. Differentiate between short and long-term regulation of blood pressure. For this, I want you to look at figure 18-13. What are those mechanisms that work quickly to help regulate our blood pressure versus those that are slower acting? And then again, review, this is my favorite, the renin, angiotensin, aldosterone mechanism. I provided you with that graphic a while back, and I asked you to laminate it and put it under your pillow, that you'll be back to it. And here we are back to it. So I do want you to review the role of renin. It says in this outline angiotensinogen, which comes from your liver, which is a precursor to angiotensin 1. Angiotensinogen really has no other function other than to convert to angiotensin 1. And angiotensin 1 doesn't have any function other to convert to angiotensin 2. And angiotensin 2 is actually the workhorse. So in this case, we can kind of bypass the angiotensinogen and angiotensin 1. So look at the role of renin, angiotensin 2, angiotensin converting enzyme, which is the enzyme that converts 1 to 2. That's ACE, angiotensin converting enzyme. Aldosterone, just to refresh you, aldosterone, one of the 3 hormones secreted by the adrenal cortex, and vasopressin, or ADH, antidiuretic hormone, and that comes from the pituitary. So look at figure 18-15 for how all those work together, and if you can, dig out that graphic that I gave you about the RAS system, the renin, angiotensin, aldosterone system. You should know the difference between primary and secondary hypertension, or what we sometimes call, instead of primary, essential hypertension. And recognize that hypertension is the number 1 cause, along with diabetes, the number 1 cause for renal failure, as well as coronary artery disease, etc. So hypertension is a big deal, and the ability to regulate and get hypertension under control is really an important factor. Read about how genetics, race, age, diet, sodium intake, obesity, and alcohol can all affect hypertension, and then realize which of these we can change and which we can't. Obviously, we can't change what race we're born. We can't change, we can't really change our age. To this point, we can't change our age. We can't change our sodium intake. We can change our basal metabolism and our BMI. And if we're obese, we could be motivated to lose weight. And obviously, if we're consuming alcohol, we can cut down on that. Relate hypertension to kidney problems. And then identify the target organs, and I've just alluded to kidney as one, the target organs that are most likely to be damaged from hypertension. I want you to look at what are the roles of some of these medications when it comes to hypertension. What are the roles of diuretics, the roles of ACE inhibitors, and let's say calcium channel blockers. Those are our major blood pressure medication categories. You should be able to differentiate between a hypertensive crisis and a hypertensive emergency. And then I say we don't talk about pediatrics or really OB very much, but there is hypertensive disorders associated with pregnancy that I'd like you to at least be familiar with, the hypertensive disorders of pregnancy. I would also like you to know the definition of orthostatic hypotension or postural hypotension, which is basically when I sit or stand, my blood pressure drops. Very frequently associated with low blood volume or insufficient blood volume, sometimes easily corrected. Look at figure 18-16 for an overview of orthostatic hypotension. And then what is the treatment for that? I'd like you to also look at figure 18-17b, and that has to do with problems with your veins, varicose veins specifically. And I'd like you to be able to differentiate these terms: venous thrombosis, thrombophlebitis, and DVT, which is deep vein thrombosis. So those are all problems that affected the venous side of the circulation. So that is it for chapter 18. Chapter 19 is disorders of cardiac function, and this chapter really relates to disorders of the specific 3 layers of the heart muscle. And it's a prelude to chapter 20, which is heart failure, which is the big one, heart failure. So in chapter 19, just review the coronary blood flow, and again, you could refer back to that video that you looked at in the previous chapter. I think that was actually in chapter 17. And what is the pathogenesis? In this chapter, there'll be a depiction of the pathogenesis of coronary artery disease. Coronary artery disease is huge, and it develops over time, and very often there are very few signs and symptoms that get a patient's attention. I should say there's very few symptoms. There could be some signs, and if you go in for an annual checkup, one of the signs could be that you have hypertension. And a physician might do a peripheral circulation evaluation, look at your ankles, for instance. Do your ankles get puffy? Is there something called pitting edema, where you are compressing the ankle right behind the tibia to feel for a posttibial pulse, and when you lift your fingers up, there's actually an indentation left from where your fingers are. Same thing on the top of the foot. If you're looking for a pedal pulse, you press your fingers down, trying to find and evaluate a pulse, and then you lift your fingers up and you see indentation. That is called pitting edema, and that is a trademark symptom of heart failure, or at least unmanaged hypertension. There's an issue there that needs to be addressed. People should not walk around with that kind of edema. It needs to be addressed. So do look at the pathogenesis of coronary artery disease. And there's going to start to be a discussion of plaque. Plaque, which reverts back to the presence of atherosclerosis, because much of that plaque is a result of bad lipids circulating in the blood. So I want you to be able to define acute coronary syndrome and an ST elevation MI. So we're starting to get some disorders that are related to EKG interpretation, which I don't want you to focus on. But an STEMI, which is capital S, capital T, capital E, STEMI, STEMI, is an ST elevation MI, and that is bad. And the other things we do when somebody comes in with a ST elevation MI, meaning they're presenting with the signs and symptoms of an MI, and on EKG we see this ST elevation, that is showing us that there is damage to the heart occurring right now. We're in the presence of someone having a myocardial infarction. We're also going to look at cardiac enzymes to see if the cardiac enzymes are elevated in correlation to that, what we're seeing on the EKG. And of course, we look at the patient's symptoms, and we expect to find irregularities in all of those areas. So I do want you to read about STEMI and to understand what the treatment options are for STEMI. And then look at the definitions of angina, A-N-G-I-N-A, I say angina, some people can say angina. Both are considered correct, so you can pronounce it any way you like. There is chronic stable angina or angina, and there's also variant or vasospastic angina. Look at figure 1911 to help you differentiate the various kinds of angina. Then moving on to the disorders of the endocardium. Remember we said the endocardium is the innermost lining of the heart. And there are disorders like infectious endocarditis and rheumatoid heart disease that can affect the endothelial lining of the heart and cause problems. So I want you to read about those. What is the way, how do we diagnose those, and how do we treat those? And then move on to look at valvular heart disorders. And previously we looked at those 4 valves, and I just want you to know that each of those valves has disorders associated with them and what you might expect to see in each. I'm not going to test you on mitral valve stenosis, for instance, or regurgitation or prolapse. I don't really expect you to do that deep dive to get on in there to understand at this point what all those valvular disorders are. You will be understanding them as you progress through the nursing program, but just knowing your valves, knowing that there are these disorders associated with them and what kind of problems they could cause, I think is sufficient for our purposes. Moving on to the disorders of the pericardium. So the pericardium, again, is that outer lining. I want you to understand what pericarditis is, pericardial effusion, constrictive pericarditis, and then as those previously named disorders are not treated sufficiently, the patient can end up with pericardial tamponade, which can be fatal if there's no intervention. So I want you to look at figure 1917 for an overview of pericardial tamponade and how that affects cardiac output and why somebody could die from pericardial tamponade. Lastly, look at the cardiomyopathies. Cardiomyopathies in general, when I hear cardiomyopathy, I think of hypertrophy, enlargement of the heart. Any kind of enlargement of the heart, any kind of cardiomyopathy means that the pumping action of the heart is impaired in some way, shape, or form. Whether it's an anatomical disorder or whether the patient acquired it as a result of some kind of an infection. Exposure to certain drugs can leave you with a cardiomyopathy, sometimes prescribed antibiotics for some exotic infection, but cocaine users are at very high risk for cardiomyopathies as well. So here I want you to look at chart 19-2, and that is it for chapter 19. And lastly, in this week, we're going to look at chapter 20, which is heart failure and circulatory shock. Heart failure, pump failure, congestive heart failure, it used to be called CHF. You'll still hear the term CHF, but most texts have moved to just call it heart failure because that's what it is. And I want you to be able to define heart failure. And how is heart failure related to cardiac reserve? Again, you're going to review that Frank Starling's mechanism that I spoke about in chapter 17, how that relates to heart failure. Again, you're going to look at the term ejection fraction, also mentioned in chapter 17, and how that relates to heart failure. I'd like you to be able to differentiate between right-sided heart failure and left-sided heart failure. So when you realize that the right side of the heart's job is to pump to the lungs, the left side of the heart's job is to pump back to the heart and to the rest of the body. We're going to get a different clinical picture of a patient with right-sided failure versus left-sided failure. And then there are patients who have bilateral heart failure as well. But it's important to be able to understand the difference between the right-sided failure and the left-sided failure. So here in our objectives, we say, what are the manifestations of right-sided versus left-sided heart failure? Understand how fluid retention and edema, as I mentioned before, play into this. The other signs we'll see are fatigue, weakness, sometimes cognitive impairment. It can sometimes actually affect the way you think. And certainly malnutrition, as your heart is pumping inefficiently, it increases the risk for cardiac arrhythmias and then also sudden death. So these are important concepts when we're talking about heart failure. And I'd like you to know about the pharmacological and the non-pharmacological interventions and treatments for heart disease. And those include those categories of medications that I mentioned earlier: diuretics, ACE inhibitors, angiotensin converting enzymes inhibitors. So remember I said that angiotensinogen converts to angiotensin 1, which really does nothing until it's converted to angiotensin 2. Our workhorse here is angiotensin 2. So ACE, angiotensin converting enzyme from the lungs actually, is required to convert that angiotensin 1 to angiotensin 2. So if we want to affect that part of the mechanism, we can give a patient an ACE inhibitor and prevent angiotensin 1 from converting to angiotensin 2. So we have less angiotensin 2 to deal with. So that helps us in some ways for some patients. So that would be why we use ACE inhibitors as first line for blood pressure management, also when we're treating patients with heart failure. Not every patient can tolerate an ACE inhibitor. So if your patient is not a candidate for an ACE inhibitor, another choice might be an angiotensin receptor blocker. So we can't affect the production of angiotensin for this patient, let's say. Patient B can't take an ACE inhibitor. So we can't affect the production of angiotensin. But by giving an angiotensin receptor blocker, or what we call an ARB, by giving an ARB, even though we can't affect the production of angiotensin, we can affect the receptor sites. So we can't do anything about the amount of angiotensin, but we can block its, let's say, absorption or activation, because the receptor sites become non-receptive. So we can control blood pressure and sometimes heart failure with those kinds of medications. And then we can also give beta blockers and vasodilating agents. And then the go-to would be a cardiac glycoside like digoxin. I know this is not a pharmacology class, but this chapter I'm sure will mention digoxin. And digoxin has been around for a million years, and it is still used today as a very effective medication to increase cardiac contractility and decrease cardiac rate, which helps in many patients who have heart failure. Okay, moving on to a different mechanism now. I want you to be able to differentiate various types of shock. So we have hypovolemic shock. I want you to look at these figures. Figure 20-7, 20-8, 20-9, and there's a chart 20-1. Hypovolemic. Hypo, use your medical terminology. Hypovolemic, insufficient volume. So there's hypovolemic shock. There is cardiogenic shock, which is when the heart is the culprit. If you're having a myocardial infarction, you could start to suffer from cardiogenic shock. There's obstructive shock and distributive shock. Distributive shock could be an example of someone who's having an anaphylactic reaction. And even though they have sufficient volume and their heart is pumping sufficiently, and maybe pumping quickly, but it's pumping sufficiently, there's this leaky capillary membrane phenomenon going on, and the fluid is not getting to target organs because it's leaking out of the vessels. So we call that distributive shock. It's not, your blood volume is not being distributed adequately. So those are the four major categories of shock that I'd like you to look at, and then also differentiate the complications of those various kinds of shock. I've got a list here of things I want you to look at. So when your body goes into shock, these are some other things that can happen. One is, well, imagine, so your body's in shock and it's not getting sufficient blood volume. Blood and oxygen perfused to the lungs, then that patient is at risk for ARDS, or adult respiratory distress syndrome. What about you're not getting sufficient blood and oxygen to your kidneys? Your kidneys are at risk for acute kidney injury, we call it, or renal failure, acute renal failure. GI complications, as your gastrointestinal tract is not being perfused, you could start to have ischemia along the GI tract, which means that ischemia could go on to develop necrosis, which means that the lining of your GI tract is going to stop functioning. Also, there's a coagulation disorder called DIC, disseminating intravascular coagulation, DIC. And back in the days when I worked in ICU many, many years ago, if patients had a diagnosis of DIC, the slang would be death is coming, because that is a very complex coagulation disorder where all of the clotting factors are used up. Did we already talk about DIC? Maybe we did when we were talking about disorders of the blood. Possibly we talked about it. So you've got all of your clotting factors being used up. So you've got microclots circulating everywhere. And you can imagine clots are no good for any of your organs, your brain, your heart, your kidneys. All of your clotting mechanisms are, all of your clotting substances are used up. So what you're left with is bleeding, and your patient starts to bleed. Yes, we did talk about this already. Your patient starts to bleed from basically every orifice. So it's a complex bleeding disorder, needs to be treated by probably more than one doctor in an ICU setting. And then also we have a disorder called multiple organ dysfunction syndrome, or MODS, MODS, and this is a precursor for sepsis, when you have multiple organs now starting to fail as a result of improper or inadequate perfusion. So that is it for week 7. Don't forget that you have a case study to do for this week on Canvas, and have a good week. And let me know if you have any questions about anything, and I will see you in week 8. Thanks.